Good evening, everyone. It's a pleasure to have all of you here today on a Friday evening talking about metastatic breast cancer. So, it's a pleasure to invite all of you for this international speaker program, which is going to be on the talk of early line integration of eribulin, which is a paradigm shift in the treatment of MBC. We are very honored to have Professor Chris Twelves here with us. But before we begin, just to give you a small overview of who are we. So Gennova basically is a biotechnology firm based at Pune. What exactly we do? We manufacture biotherapeutics. How exactly we do that is by manufacturing technologies which in turn transform healthcare. We have the vision to be one of the most technologically advanced companies in India. We aspire to transform the healthcare of millions of people, especially through the implementation of technological solutions, and in this process, become the top 10 technology driven countries of the world. Today, we can say that in the last 10 years, we've touched thousands of patients, and in the coming times, we hope to touch millions of them as well. This is just to show you 2 decades of excellence, of innovation that we've had. So we've launched Elaxim, Vintor, Mgrast, Pegex, and a lot of the other vaccine formulations as well. Even when it comes to ALL, we have Hamsil for oncology and Tenectase for stroke. And even during the COVID times, we had Semcovac 19 vaccine, which is the thermostable vaccine of India. And recently, we launched the Hamsil Junior as well for pediatric cancers. So, in a nutshell, we are care leaders in the field of stroke care and management, mRNA vaccines and biotherapeutics, and cancer care and management. So, with this, I would like to hand it over to our chairperson for today, Dr. Sham Agarwal. Sir, it's a pleasure to have you here today. Sir definitely doesn't require any introduction. Sir is the chairman and senior consultant at the Medical Oncology, Sir Gangaram Hospital, New Delhi. Sir is going to talk to us about an evolving clinical challenge, which is breast cancer. Over to you, sir.
So, good evening, everyone. Thank you, Ronak and Genova, for giving us this opportunity to join on this platform for a discussion on metastatic breast cancer. And we also welcome Professor Twells, who has joined us from UK Lead for this discussion. So, my job is to introduce the subject and do the context setting for breast cancer. Next slide, please. So, as we are all aware, that globally breast cancer is number two in terms of incidence, and in terms of mortality, it stands at number four after lung and stomach and colorectal and liver cancer. So, but the situation is a little different in India. Next slide will show that. So we have nearly 200,000 new cases each year, and you can see almost half of these patients are sort of dying. The mortality is quite high in our country, and breast cancer has become number one today in women in India. Next slide. This has surpassed cervical cancer in the last few years. So we have a fair tumor burden of patients with metastatic disease. But then if you look at the classification and the subtypes of breast cancer, invasive ductal carcinoma constitutes around 80% and lobular 10%, and the rest are constituted by medullary carcinoma, mucinous, tubular, inflammatory, being about 2.5%. And there's a small percentage of phylloids tumor as well. So most of the tumors which we encounter are invasive, ductal or lobular, but you can also see DCIS or lobular carcinoma in situ. When it comes to particular subtyping of the breast cancer, we have luminal A, B, and then if you were to do the ER/PR HER2/neu, we have ER positive in luminal A and luminal B, and HER2, today is being now categorized as HER2 positive, HER2 low, and HER2 ultra low, depending upon the IHC, markers. Triple negative, of course, is there, which can further be, subclassified at the molecular level, which we don't do routinely. Then, I mean, it's not a single disease; it's a heterogeneous disease, and requires different modalities of treatment depending upon the subtype of breast cancer. Next slide. So this is, what we were referring to. Like 15 to 50% of breast cancer patients in India report, in the late form, and therefore the incidence of metastasis is much higher, which sort of results in a higher mortality. This is opposed to the Western countries where the incidence of early breast cancer detection is quite high, and therefore the cure rates are quite high, possibly due to socioeconomic status, lack of mammography facilities, people not getting their mammograms done. So I think that's an unmet need in our country at this time. But I think over the years, the incidence of advanced cancers at the time of detection have come down. But I think there's a lot of further work needs to be done, because in the US and in the Western countries, 60, 70, 80% of the women will do annual mammograms and facilitate early detection. Whereas in India, only 2%, 3% women would do the annual or mammogram in once in 2 years after the age of 45 years. So that's a huge, huge area of work. Next slide. So, these are some of the uh, sort of guidelines for, patients who are uh, diagnosed with metastatic disease. I think currently PET CT scan is so very common, which is required to be done by and large. And of course, outset, we need to perform the ERPR HER2 new, and depending upon the subtype of breast cancer, one can also look at BRCA1, BRCA2, and next generation sequencing. Next slide, please. So, these patients who have local recurrence, then the subsequent treatment depends on whether the patient has had prior radiation or no radiation. And if there is a local regional recurrence, one can opt for upfront surgery, or go for systemic therapy and downstage the disease before surgery is performed. And if radiation has not been done, then radiation can also be considered in these individuals, followed by adjuvant therapy, depending upon the ERPR and HER2 new status. Next slide. So again, depending on the type of recurrence and the kind of surgery which the patient had received earlier, one needs to individualize the patient if the patient has had axillary dissection or no. Depending on that, systemic therapy can be utilized, and then surgery and radiation can be done. Next slide. So I think there is a significant role for supportive care for patients who are in metastatic disease. Patients who have bone disease, they should be given additional either denosumab or zoledronic acid. And if bone disease is not present, well, then of course systemic therapy as per the requirement for ER positive, for HER2 positive, or for triple negative requires to be done. Next slide. So I think there's a focus on triple negative breast cancer in our country, because almost 30% or more of these patients will have triple negative breast cancer, and particularly at a young age. And as we understand, it has a bad outcome, poor prognosis, because of its aggressive behavior. Next slide. So these are some of the current guidelines, 2026, for managing these patients with triple negative breast cancer in the metastatic scenario. So I think the PDL1 needs to be done for all these patients because if the CPS is greater than 10, then one of the preferred choices today in our country would revolve around chemotherapy and pembrolizumab. Although more recently we did have the approval for using sacituzumab govitecan along with pembrolizumab. However, sacituzumab is currently not available. If the patient is, CPS less than 10, then you do have the option of systemic chemotherapy, which we use routinely in our patients because we do not have sacituzumab and we don't have dotapotamab deruxtecan, which is recommended. And basically, for patients who are germline positive, I think one has the role of PARP inhibitors like olaparib and talazoparib, and the role for chemotherapy is already there. So, depending upon what you use in the first line, the second line options would then become automatically available. And if somebody in TNBC is HER2 low, then you have the choice of using TDXD as well, which is, a recommendation after the use of chemotherapy. Then, if you do the NGS in these patients and you find them to be NTRK or RET fusion, or you find even TMB high, so one can use suitable drugs targeting those biomarkers. So I think the area has expanded because of the availability of ADCs and other targeted drugs, so as to improve the outcomes of patients with several chemotherapeutic options. Show the next slide, please. So actually, other than immunotherapy and sacituzumab, we have a plethora of chemo drugs which can be used in patients with triple negative breast cancers, which include anthracyclines, taxanes, gemcitabine, a platinum compound. And today, I think we have the focus on eribulin, which we have been using now for several years in a couple of cancers, including breast cancer, particularly triple negative breast cancer. The next slide. So this is a novel helicondrin B analog for the treatment of MBC. And as you can see, the mechanism of action of eribulin, revolves around the microtubule. It has no effect on microtubule shortening, but inhibits microtubule growth. And it crosses the non-productive tubulin aggregates, and therefore it's able to, control the cell growth. The recent data from clinical trials emphasize that eribulin has the potential as an earlier line agent in the management of patients with NBC, especially in TNBC, where options are limited and prognosis is not all that good. So I think we do have several chemo options, and the use of eribulin earlier in the management would, help patients better than as compared to using eribulin in the later or subsequent lines. So I think with this, we need to move on to the next speech, which is by Dr. Akhil Kapoor from Tata Memorial Central, Varanasi. He's going to talk about Indian perspectives, clinical insights, and real world experience. So, Dr. Akhil, over to you for the next session.
Dr. Akhil, are you there?
Sir, you're on mute.
Yeah. So thank you. So I'll be presenting a real world experience from our country, India. So we know the field has rapidly evolved and we keep on utilizing this drug. And I will share real world Indian data where we have utilized it in across the line settings, and we'll see how has been our experience. Next slide, please. So this is our study, which was published in eCancer Medical Sciences, and which has evaluated the benefit of this treatment, eribulin, across the metastatic breast cancers. It included both triple negative and non-triple negative cancers. Next slide. And this is the our study glance. First, I would like to highlight the areas. The cohort is of 100 plus patients. This is first study from the country, which is about 100 plus patients with median age of 52 years, and around 80% patients had some or the other visceral disease involvement. So this is a patient's area which has been treated heavily previously, and we will see the efficacy and safety in subsequent slides in detail. Next slide. So what is the main problem of managing MBC in resource-constrained settings? We have limited options and limited utilization of immunotherapy, especially in triple-negative breast cancer. Timely testing of PD-L1 is important, and even despite utilization of immunotherapy, if we can utilize, these do not give durable responses in majority of the patient and works in very small fraction of the patient, 10 to 20% only. And the quantum of benefit of immunotherapy is also not so large in metastatic breast cancer as compared to other cancers which we have seen. So metastatic breast cancer is a huge burden in the country, and our country sees a much younger age of the patients as compared to the West. And the young breast cancer is definitely on significant rise. And yes, younger breast cancer patients have more aggressive disease, and these have poor responses to the treatment as well due to a very rapid proliferation of the tumor. So the financial toxicity and availability of ADCs in our country is limited. In triple negative breast cancer also, these are classified as HER2 low if HER2 is either 1 plus or 2 plus with FISH non-amplified. And there is an option of ADC, TDX, which is already approved and available in our country. And heavily pretreated patients often have as compromised marrow reserves, and they tend to respond poorly, at the same time have significant toxicities to the treatment. Next slide. So this is the study. This was a retrospective audit of our center. Patients were more than 18 years, performance rate was 0 to 2. Patients have received two or more prior lines of treatment. Most of the patients had progressed on anthracyclines and taxanes. TNBC patients, most of them had progressed on platinum-based chemotherapy as well. Eribulin was utilized at standard doses of 1.4 milligram per meter square, 3 to 5 minutes, day 1, day 8 of 21-day cycles. Prophylactic GCSF support was included as a part in all the patients. And response assessment was done as per the standard institutional protocol of 3 to 4 cycles, most of the time post 3 cycles. Next slide, please. So as I told, median age slightly younger. Median age was 52 years, visceral involvement in 80% patients. More than 3 metastatic site was present in 67%. If you see, liver metastasis were present in close to 45% of the patients, lung metastasis in half of the patients, brain metastasis in 1/5 of the patients, and bone metastasis in more than 60% of the patients. And patients had median prior lines of treatment was 3, range was 2 to 5. If we see hormone positive patients were close to 48%, triple negative was 45%, HER2 a small percentage of around 5%. So yes, across the spectrum, very high disease burden, and prior lines of therapy were 3, median and range was 2 to 5. Next slide. So what we understood of heavily pretreated patients. And what we saw, response rates were above 50%. This clinical benefit rate was above 50%. Actually, this is very good. Actually, this is not a very common area where we expect so good responses above 50%, that is CR plus PR rates. At the same time, stable disease added further 10%. And so this is a good. And median number of cycles ranged from 1 to 11, with median number of cycles being 3. Next slide. Median PFS was 4 months, as you can see from this Kaplan-Meier curve. And this PFS is achieved in a third line setting consistent with global benchmarks. Study 301, which is a global benchmark study, had median PFS of 4.1 months. This is quite comparable data. Next slide. Other data sets which are important is OS. This OS was counted from the day of starting of eribulin. You can see the median OS is 10 months in third line and beyond settings. So it is a good post-eribulin context, 54% patients received next line of treatment, 45% patients could receive further best supportive care alone. Next slide. And if we see subgroup analysis of TNBC and non-TNBC, even non-TNBC patients had good responses. It is not only for triple negative breast cancer where we keep on discussing eribulin works well in TNBC, but yes, here non-TNBC patients also got had good responses, and median OS was close to 11 months for non-TNBC. This is might be due to disease biology, somewhat slower disease growth as compared to TNBC, but yes, it is clear that patients were having good responses to the treatment, and this is a good treatment option even for non-triple negative breast cancer. And especially when we are utilizing the drug in earlier lines, the responses were much better sustained. Next slide. This is the prognostic factor. If metastatic sites were more than 3, hazard ratio was 1.3. TNBC definitely had much higher risk, 2.1. And there were some other factors like elderly, presence of liver metastasis, presence of brain metastasis. These had some impact, but they did not reach statistical significance. But we don't know whether it was due to data being not so large, though it is comparatively larger data, but still it is considered a safe treatment even in above 60 years age group, which we consider as a geriatric population. Next slide. And coming to the safety profile, yes, dose reduction was required in around 8% of the patient, but discontinuation was required only in 5% of the patients. So this is very clear. The toxicity, it is a well-tolerated regimen, and grade 3, 4 toxicities are not very high, always below 10%, and highest is anemia in around 8.5%. Next slide. So comparing our data with Embrace study and study 301, Embrace study had median OS of 13 months. The study 301 has about 15.9 months, and PFS is quite comparable. OS is about due to different utilization of treatment options down the line post progression on eribulin, which was limited in our settings. It was utilized in 55% of the patients, and these patients were heavily pre-treated as well. So this is heavily pre-treated leads to somewhat reduction in the OS, which we can't understand. Next slide. So what are the implications? It is a good effective treatment option post anthracyclines, taxane, and also in platinum refractory patients. It is a cost-effective regimen. ADCs are not very easily available in the country. We have access to ADC, but through trials. Non-taxane microtubule inhibitor mechanism remains effective even in taxane-resistant tumors. This is very clear. And this is a drug which is feasible to be utilized in patients with high visceral burden, liver, lung mets, and prior heavy chemotherapy exposure, 3 or 4 lines of the treatment. Next slide. So to summarize, eribulin is a viable and safe option for treating heavily pretreated MBC patients in real-world settings, which has addressed a clinical unmet need in resource-constrained environment and demonstrates comparable efficacy to global trials. And efficacy was demonstrated both across TNBC and non-TNBC, and with good manageable safety profile with low discontinuation rates. Next slide. This is our institute. Thank you everyone for the patient listening. Looking forward for further discussions during panel. Thank you.
Thank you so much, sir, for the enlightening discussion.
So thank you, and Akhil. I think that was a great presentation for showcasing the data from your institution. I think the best part of the drug is that it can be given virtually in the outdoor setting, and it's quite easily accessible, so doesn't require, at least in our hands, any kind of admission, because the drug can be administered in a few minutes by and large. It's quite well tolerated under the cover of growth factors, as you showed that most of these patients were covered with growth factors because they are, 2 or more beyond the lines of treatment. So I think we do have this drug now. I think let's have more discussion. And before that, I think Professor Chris Twelves is here. And just to introduce him, he's Professor of Clinical Cancer Pharmacology and Oncology, Honorary Consultant Medical Oncologist, University of Leeds, UK, and he's going to talk on early line integration of eribulin, a paradigm shift in the treatment of metastatic breast cancer.
Professor 12?
Ronak, he's joining in 1 or 2 minutes.
Okay, sure.
So, Akhil, what is your longest survivor? Are you there?
Dr. Kapoor?
So,
Yes, sir.
we had,
Yes, sir.
yeah, Akhil. So, we had a few patients, who had gone beyond 11, 12 months, beyond a year. And sometimes, you have to dose adjust instead of being able to give them on a weekly basis. So when they go beyond 5 to 6 months, so we can, depending on their blood counts, tailor the treatment and give it like, once in 2 weeks, some kind of a maintenance. And they do tolerate well. Alopecia remains a toxicity besides bone marrow side effects. But otherwise, nausea, vomiting, all those, GI side effects are quite few.
Dr. Kapoor, your thoughts on the same?
So, what I understand is that the most important factor which is there, which helps us to understand the benefit of the treatment is early integration. Uh, if we keep this drug for very late lines, as other for other treatments, the duration of response will be very short-lived, and there will be some initial response, but that will not be sustained. So it is good to utilize it as early as possible, not to keep it for the last line. Otherwise, the responses will be very less, and it is the patient's marrow reserves will also, as Sham sir was trying to highlight, if we keep it very last line, the benefit will not be sustained. So I tend to utilize it in much earlier lines, most of the time in second or third line. And if patient is triple negative, platinum may be reserved for the next line also. It is not mandatory to utilize post platinum also.
We also have Dr. Pankaj Goyal sir here with us. Sir, what are your thoughts on the same? Anuradha, yes, sir.
Yeah, so been actually using this in actually maybe in hormone positive, and recently we have started using in HER2 positive also. So I think across the indications we can use it in some permutation combinations.
Yeah, and availability of eribulin plus Trastuzumab plus Per2 data
Yeah,
is also
that's
there.
what.
So
Yeah.
I think sir has highlighted an important point.
Yeah.
For HER2, we were utilizing it very low previously, but now with the strong data set that is
Yeah,
at least equally
we are all the
effective.
more confident. Yeah.
Yeah, we are much more confident.
Nirav, any update on Professor 12?
Yeah, we have just spoken to sir. He will join back soon.
Okay.
We just contacted him on WhatsApp, so he'll join soon.
Okay.
We'll wait few minutes more.
Yeah. In the meantime, we can have some more discussion from the panel which is present here, and I think we can see a lot of people who are
बुलाता
yeah,
हूँ
very
ठीक है तो मैं 2
experienced.
मिनट में
Yeah. Anybody can take a comment on utilization in non-TNBC setting apart from HER2. HER2, we have very clear data. What I found in our cohort is that patients with hormone-positive patients were also responding very well to the treatment. And there is some data published from TMS Mumbai under Sudhir Gupta sir that there are some areas where we can combine hormone therapy along with chemotherapies. So any thought about it?
Ronak ji, Professor Twelves has joined. Sorry to interrupt here.
Okay. Let's go ahead with them.
Good evening, Professor.
Hello, can you hear me?
Yes, sir.
Good evening.
Good evening. So would you be sharing the screen from your end, or do you want me to do the same?
I can try and share from my end.
Sure,
If that doesn't work, we can do it from yours.
Sure, sir. I'm just stopping my sharing. Yeah, please go ahead.
So I'm hoping you can see my screen.
Yes, sir.
Yes.
It
Just
just needs
put
to
it
be
full
put on
screen.
full screen.
Full screen, sir.
I'm just looking for the full screen, and I can't see where the full screen is. I know exactly what you mean, but I can't see the
In
where's the,
slideshow.
I know what I'm looking for. I just can't see it on this display.
At
You
the
just
top,
go
there
to
is a
bottom of
home.
right
No, it's
bottom
not.
of your slide, and you can just click on that, sir.
It should be, but it's not. It's not there. Let me just try it
Sir, it's
again.
at the top, at the right of animation slideshow.
Yes.
Or do F5.
No, no.
Yeah,
Yeah.
from beginning.
From beginning.
F5. Press F5 on your screen.
Yes.
Keyboard.
That's
Keyboard.
perfect.
Please go ahead, sir.
Yeah.
Is that good now?
Yes.
Yes, sir.
Absolutely good, sir.
Thank you.
You can
Hello?
begin, sir. You can begin, sir. We can see.
Okay. Sorry, I wasn't sure if we're waiting for an introduction. Oh, I'm sorry. Have I just lost the slide? Share? Is that back again? Okay, so if I can start then, thank you very much for the opportunity to speak about eribulin this evening. I would love to be with you in India. It's some years since I last visited, but I've always enjoyed coming to India. But anyway, it's nice to be speaking anyway on something that is very close to my heart. And you see there my different roles. I'm a clinical academic in Leeds, which is a city in the north of England. So these are my disclosures, and I should emphasize that I have done quite extensive work with Azyme in the past around eribulin. So when I started preparation for this presentation, as a starting point, I found this article looking at the use of eribulin in people with metastatic breast cancer in the real world setting. And this caught my attention because I have a good awareness of how we use eribulin in the UK, but I really didn't have a very clear idea of how eribulin is used in India. And there were a couple of things that struck me. I suppose first was that I'm pleased to see that eribulin is indeed being used in people with metastatic breast cancer. But when I looked at the subpopulation of people that were treated, it looked as though it was almost half of them were people with triple negative breast cancer, which certainly is a higher proportion than it would be in our practice. And I was even more struck when I looked at the lines of therapy where eribulin was being used, with the majority of patients, about 70% of patients, receiving eribulin as fourth or fifth line treatment. Again, later line treatment that would be the case in my own practice in the UK. Another point that I thought I would just highlight as part of the introduction here is the issue of overall survival in clinical trials. I've been a trialist for many years, and we invariably would use progression-free survival as our primary endpoint in clinical trials. But when eribulin was being developed, because we had a number of other cytotoxics, a number of other chemotherapy drugs potentially available for us, we were very keen that eribulin offered something new, something different, rather than just being another me-too microtubule inhibitor. And the reason we chose overall survival as the primary endpoint for the EMBRACE study and the co-primary endpoint for study 301 in those pivotal studies you'll remember from many years ago, was that overall survival is actually what is the most important or preferred endpoint for patients with metastatic breast cancer. If you look at the bottom of the slide there, you see on the numerical scale how heavily or highly individuals weighted particular aspects of their systemic anti-cancer therapy. You can see that the ability to improve survival was more important than slowing the cancer growth or improving quality of life. So for patients, improving overall survival is of major importance. It's also the gold standard for regulators, and indeed, I think as clinicians, one of our when we're faced with people who have got metastatic breast cancer who will die of their disease, helping them live longer as well as living better is important for us. And eribulin was, and I think remains, unique in being a chemotherapy drug which is able to prolong overall survival in patients with pre-treated metastatic breast cancer. The other perspective that I have, and again, this is partly a historical perspective, is that I think we sometimes forget, in the context of all the new treatments that are becoming available, that the mainstay of clinical practice across the range of subtypes of metastatic breast cancer remains chemotherapy. And this is a review that we did about 10 years ago, I think it is now. Some of you may know Ahmad Awada from Bordeaux, who I've worked with extensively. And between Bordeaux and colleagues in Leeds, we did this review really focused around the role of chemotherapy. And I think that is still true 10 years later. For people with hormone receptor positive, HER2 negative breast cancer, we have a number of endocrine agents, we have a number of combination endocrine therapies. But once people become resistant to those endocrine therapies, we look to chemotherapy. And similarly, in people with visceral crisis, where there is rapid progression of their disease affecting major organs, we would look to chemotherapy sooner rather than later. So despite the advances in endocrine therapy we've seen over recent years, chemotherapy remains important for people with hormone receptor positive, HER2 negative disease. Similarly, if we look at people with HER2 positive, hormone receptor negative disease, again, we've got important new treatments in the form of antibody drug conjugates and different HER2 targeted therapies, but chemotherapy remains central as a partner to the HER2 targeted therapies. And in triple negative breast cancer, where treatment options have been very limited until recently, chemotherapy remains central to treatment despite the emergence of drugs such as sacituzumab, govitecan, and for people with BRCA mutations, olaparib and talazoparib. So I think it is important to remember that chemotherapy does remain at the heart of how we treat people with metastatic breast cancer. I was also interested to look at the pattern of publications around eribulin over the last 25 years. You can see that the first preclinical publication goes back to 2001, but the publications in the clinical arena, my first publication with eribulin was in 2010 with the EMBRACE trial, the phase 3 randomized trial that we published effectively halfway through this period. And in all, when I looked, there were 23 publications that I've had with eribulin. So this has been a major interest to me. So what I wanted to do to start off with was to go back and look at those pivotal studies reported initially in 2010, 2012 or 13, on which the initial regulatory approval of eribulin was based. And you see on this slide, the two key trials on the left-hand part of the slide. There's the study 305 or the EMBRACE study, and on the right-hand side of the slide, study 301. They were both studies in people with metastatic breast cancer previously pre-treated in the metastatic setting with at least a couple of lines of chemotherapy, and patients had all received a prior anthracycline and a taxane. In the trial on the left, the EMBRACE trial, the randomization was between what we now think of as the standard dose of eribulin and treatment of physician's choice. And that in itself was novel at the time. It was conventional in clinical trials to choose a single control arm chemotherapy or standard treatment. But we felt at the time that that didn't reflect clinical practice, where we knew that patients were receiving a range of different treatments once they'd received at least a couple of lines of chemotherapy. So we identified and we adopted this treatment of physician's choice, within this study, overall survival as the primary endpoint. The second study on the right, study 301, was similar. It's a large randomized trial, this time a one-to-one randomization, and the control arm was a standard treatment in the form of capecitabine. And in this case, there were co-primary endpoints of overall survival and progression-free survival. This is the patient characteristics of the joint analysis that we conducted once we published the individual analyses of the two studies. So you can see the different patient populations, and I just draw your attention to a couple of things. I'm sorry, I meant to go back there. So if we look at the number of previous regimens for advanced disease there, you can see that only about a quarter of patients had received more than 2 lines of chemotherapy for metastatic disease. So the majority of patients in these two key studies were much less heavily pre-treated than the patients who have been treated in routine practice in India. And if we look again towards the bottom of the slide at the proportion with triple negative disease, that's less than 25% in the pivotal trials, again, much lower than the nearly 45 or 50% in the current Indian experience. So this is the overall survival data for the combined analysis of study 301 and 305. So this is eribulin in the darker line compared to the control arm, which was either treatment of physician's choice or capecitabine. You can see that there's clear separation of the two curves, really along the whole history of the Kaplan-Meier plot here. You can see that the hazard ratio for death is 0.85 and a highly significant p-value shown in the annotation there. And this was effectively the first chemotherapy treatment shown to significantly improve overall survival in pre-treated patients. Here you see the forest plot looking at overall survival, highlighted here as the overall population, where we see that hazard ratio of 0.85 and a statistically significant improvement. But we see a very similar pattern across all of those subgroups that were previously or selected up front for analysis. So if we look at the hormone receptor positive and the hormone receptor negative, you can see that there is significant benefit in both groups. If we look at the HER2 positive and the HER2 negative, the HER2 positives were actually a small group, so the confidence interval crosses the midline, but the point estimates are very similar, suggesting benefit from eribulin in people who have HER2 negative as well as HER2 positive metastatic breast cancer. And then highlighted here are the people with triple negative disease, and you can see there is a striking benefit in those with triple negative breast cancer, shown with that marked separation and highly significant result. But interestingly, that rather larger number who didn't have triple negative disease, again, they had significant benefit. So we see benefit across the different molecular subtypes. It's true that the data are particularly striking in people with triple negative breast cancer, and that's shown here where we've got the data from the eribulin versus capecitabine comparison in study 301. And you see clear separation, particularly clear separation and improvement of several months in overall survival with eribulin compared to capecitabine. But I think it's important to remember that the benefit of eribulin in people with metastatic breast cancer is not limited to those with triple negative breast cancer. Importantly, also, that improvement in overall survival wasn't at the expense of quality of life. Overall survival improved, and there wasn't a deterioration in quality of life, as was shown in the data from study 301, where we looked specifically at quality of life with eribulin compared to capecitabine. Most of us would think that capecitabine was generally well tolerated and associated with a good quality of life, but we saw very similar quality of life overall with eribulin, despite or in addition to its improved overall survival. So in the context of the current presentation, I think my first conclusion is that the improvement in overall survival that we see with eribulin is confirmed or maintained across the molecular subtypes with quality of life maintained, and not just in people with triple negative breast cancer. So those were the data that led to the approval and the widespread adoption of eribulin in people with pretreated metastatic breast cancer. And this led to, as I say, widespread use in Europe and elsewhere. And real-world data were subsequently reported. And I think maybe one of the best examples of the real-world data are the data from the ESME database, which you may be familiar with. This, as the slide says, is the real-life activity of eribulin in 16,000 metastatic breast cancer patients in a multi-center collaborative study from the centers you see highlighted there across France. So about 1,500 of the patients received eribulin, and their outcomes were compared to the remainder of that 1,600 who didn't receive eribulin. And you can see in the three panels there, the overall survival differences in the second, third, and later line settings. And you can see that there is consistent separation of the curves. And if we, in particular, separated out the hormone receptor positive HER2 negative patients, then the significant benefit with the eribulin was confirmed across the settings, across the lines of treatment. Now, we all know that there are limitations to real-world data, but I think this study does qualify as what I consider real-world evidence, because the data here is a very well curated data set. It's from a set of very good centers. And although it's impossible to eliminate potential bias, I think this is a very strong pointer to the benefits of eribulin in second, third, and later line settings in people with metastatic breast cancer. We also did analyses of the pivotal studies looking at people who are treated, who are less or more heavily pretreated for their metastatic breast cancer, as you see on the slide here. And if we looked at the EMBRACE trial, there was greater benefit for patients if they were treated with the less than or equal to 3 lines of prior chemotherapy than if they were more heavily pretreated. And when we looked at study 301, the straight comparison of eribulin with capecitabine, again, if we looked at the patients who were treated in the second line setting, the patients treated in the second line setting did better than those who were treated in the later line settings, with an improvement of overall survival of more than 2.5 months compared to less than 1.5 months in the later line setting. So the pointers from those two pivotal trials indicating earlier rather than later use of eribulin to be recommended. And we did the same joint analysis, and here you see looking at the overall survival in patients treated with less than or equal to 3 lines of chemotherapy, and the text at the bottom of the slide shows that again the median overall survival benefit was greater in those who are less heavily pretreated. And I'd highlight here that we're not only saying that the people treated in the earlier line of therapy live longer, that's to be expected because they're less far along in the natural history of their disease. What we're looking at here is the benefit in overall survival, and that a gain in overall survival was more marked in people who received eribulin who were less heavily pre-treated. There was also another study which has been less widely publicized, another ASI-sponsored study looking in Chinese population at people treating people with eribulin compared to vinorelbine, another alternative chemotherapy for people with pre-treated metastatic breast cancer. You see the eligibility criteria on the left-hand side of the slide, and you can see there that they were randomized 1-to-1 to the standard eribulin or to a standard dose of vinorelbine with a co-primary endpoint of overall survival and progression-free survival. The hazard ratio for progression-free survival is shown in the forest plot here and highlighted at the top of the slide. You can see that the point estimate lies to the left of the vertical line, to the left of the midline. So overall survival was superior in the people treated with eribulin compared to vinorelbine in the overall population. And highlighted here are the patients who are less heavily or more heavily pre-treated. And you can see, looking at this in two different ways, that those who had received fewer previous lines of chemotherapy in the metastatic or advanced setting were those who benefited from eribulin in terms of the improved overall survival. Again, a pointer towards using eribulin sooner rather than later. But for me, maybe the clincher in this discussion is this slide here. And this is a slide that, from a paper we published again several years ago. And here we were looking at a population of our own patients with hormone receptor positive, HER2 negative breast cancer, and looking at their outcomes through successive lines of treatment. And what you see here is that when we looked at this cohort in the first line, we had about 180 patients over a period of, I think it was about 3 years. And as we followed these patients through their first to second, third, fourth, and fifth line of treatment, you can see that there is a step down on each occasion in the number of patients that go on to receive their next line of therapy. Some of them are alive, but don't receive further treatment, presumably because they're not sufficiently well or decline treatment. Many of them die. And on each occasion, it's about 60–70% of patients who go on to receive the next line of therapy. And for me, the clear implication here is that we should be using our more effective treatments sooner rather than later, because otherwise a substantial proportion of patients are going to miss out on the opportunity to benefit from that potentially better treatment. So my second takeaway for today would be that there are consistent benefits using eribulin earlier as second rather than third line or later treatment. We've seen that the overall survival gains are greater, but this also avoids patient attrition. So all of the data that I've shown you so far have been in the context of the data that were around at the time when eribulin was initially approved. But clearly things have moved on since then, and there are a number of additional studies that have subsequently been conducted, many of them looking at eribulin in earlier line setting, looking at first or second line treatment rather than second and later line treatment of metastatic breast cancer. And there are a number of slides which really have rather similar outcomes and similar data which we can look through without spending too much time on any individual slide. So here you see a single arm study from Japan, conducted over a 3-year period at a number of centers in Japan. You can see that the overall response rate was over 40%, the median progression-free survival over 8 months. The adverse events were those that we would expect from the pivotal trials. If we look at the top panel on the right there, you see the waterfall plot showing an impressive proportion of patients to the right-hand side with the vertical bar going down, indicating patients whose tumors are shrinking to a greater or lesser extent, and the progression-free survival is shown in the panel below at just over 8 months. So these are good data. These are data comparable to the efficacy of a taxane or capecitabine in early line treatment of metastatic breast cancer with an acceptable safety profile. These are data from the US, similar data. These were patients who were more than 12 months out since their prior neoadjuvant or adjuvant chemotherapy, but they were a group of patients who had mostly received prior taxane or prior anthracycline. So this was a group of people who I think we all are familiar with in our clinical practice, who have received the anthracycline or the taxane as prior to them developing metastatic breast cancer, and where I think there is a real question as to whether these patients may benefit from the earlier use of eribulin. Again, the waterfall plot at the top of the slide shows an impressive response rate and clinical benefit rate of around 50%, and again, a progression-free survival of just under 7 months in this higher risk or poor prognosis group of patients. Here we have a first-line study, again from Japan, but what is striking to me is that the patients are receiving a median of 8 cycles of treatment, suggesting that they're benefiting for a period of around 6 months. The response rate and clinical benefit rate are 54% and 63% respectively, progression-free survival of 6 months, and overall survival of nearly 36 months. So again, in the earlier line setting, in this case, first line setting, in HER2 negative metastatic or locally advanced breast cancer, eribulin showing encouraging results. One of the striking features in the pivotal trials with eribulin, but also in the vast majority of trials that we see, is that the patients in our trials tend to be younger than the patients who we treat in our regular clinics. This is a smaller study in people over the age of 70 that came out from the Swiss group. And in this study, they used a slightly lower starting dose of eribulin, but the activity of eribulin was maintained. And the suggestion was that, in fact, most patients who are elderly may not need a dose modification. But again, suggesting that this earlier use of eribulin here in the first-line setting can be applied also to those older patients who we see so often in the clinic. Again, we've got another study here. This is the so-called Meribel study, which is a more recent study. Again, this was a study in people with more aggressive disease. So these were people who had taxane pre-treated HER2 negative metastatic breast cancer, and they'd had a disease-free interval of less than 3, or later in the study, less than 4 years. So again, similar to that poor prognosis group of patients in the American single-arm study we saw earlier, where they were looking at treatment first or second line, here we have a first-line, exclusively first-line study in this poorer prognosis group of patients. There were just 53 patients in the study, but the age range was extended up to 83 years. And the disease-free interval of over 15 months, I think, is notable. These were the majority of patients relapsing in less than 18 months. And despite that, there was a time to progression of 4 months and a response rate of over 20%, clinical benefit rate somewhat higher. And you see those demonstrated, the time to progression in the top panel on the right, and the waterfall plot in the panel to the bottom. So again, single agent use, first line in a poor prognosis group of patients with eribulin showing clear benefits. There have been relatively few randomized trials of eribulin as first or second line treatment. These are expensive and difficult trials for cooperative groups to conduct, but there have been a limited number of trials. And this is one such trial from Japan, looking at first or second line use of eribulin. The study design is shown in the panel on the left. So again, these were people who'd received a prior anthracycline or taxane for their early breast cancer, and then when they relapsed, they were randomized to receive either eribulin or treatment of physician's choice again. And that treatment of physician's choice, you see, comprise paclitaxel, docetaxel, nab-paclitaxel, or vinorelbine. So all very respectable agents in the first-line setting. You see the response, the efficacy data shown on the right-hand part of the slide. You can see that the progression-free survival and the response rates all favored eribulin over the treatment of physician's choice. And you see on the right-hand part, on the bottom right of the slide, the progression-free survival and the time to treatment failure. Again, the black line represents the eribulin patients, the red line, the patients treated with the treatment of physician's choice. And again, we see the data favoring eribulin in the first or second line setting. A second randomized study is one that came out of Japan again. This was a study looking in the first line or second line setting at the comparison between eribulin and the oral 5-FU fluoropyrimidine S1, looking at both overall survival but also quality of life in people with HER2 negative disease. You can see that the data on the right-hand part of the slide show that the time to the deterioration in the quality of life was very similar between the two, but also that the overall survival, although this study wasn't powered primarily around overall survival, the median overall survival favored the eribulin compared to S1. There have been other evaluations that have been carried out. Here you see a retrospective evaluation, so this wasn't a prospective clinical trial, but in this group of patients that you see there, 172 who received eribulin, 129 who didn't. The median overall survival favored those who received eribulin, and in a multivariate analysis, in looking specifically at the prior, the patients who, at the effect of prior neo or adjuvant or adjuvant anthracycline and or taxane use in the patients who had received the prior anthracycline or taxane, then there was this predicted for overall survival from benefit from eribulin. Again, I think speaking to the role of eribulin in the earlier line, potentially first line setting in people who have previously been exposed to anthracycline and the taxane as treatment of their early breast cancer. This is a real-world study. I won't dwell greatly on the real-world studies, other than to say that the real-world studies have shown very similar outcomes to those that have been seen in the actual clinical trials that we've seen here. They were looking at early line therapy, demonstrating a superior benefit in terms of progression-free survival compared to the later line therapy that you see shown on the top right-hand panel. The early line therapy in the black line, first or second line, those patients faring better than those treated in the third line or later in terms of progression-free survival. And they also looked at patients treated with combinations, with eribulin given in combination and eribulin given as a single agent. And you can see again that benefit for the earlier rather than the later use of eribulin was maintained. This slide is a bit of takes a bit of a jump, but just I think this is an interesting focus as we look towards the first line use of eribulin, because generally I think most of us would use or have used capecitabine or paclitaxel as our first line metastatic chemotherapy. And this slide shows a comparison of eribulin compared to paclitaxel. The left-hand part of the slide is a randomized phase 2 trial in which the patients all received gemcitabine, but they were randomized either to receive eribulin or gemcitabine as first-line chemotherapy. The design is shown in the bottom left panel, and the outcome is shown in that central panel at the bottom there, labeled A. And you can see that the PG, which is the paclitaxel, and the EG, which is the brown line, they are very similar, with a 6-month progression-free survival of around 6 months. The right-hand panel shows a systematic review that was carried out looking at the question of paclitaxel versus eribulin in a whole range of different clinical trials. This was carried out some years ago and reported in 2024. That systematic review identified 5 studies where there was a comparison between a paclitaxel regimen and an eribulin regimen. Most of those were comparisons in a neoadjuvant setting where the paclitaxel or the eribulin was given, followed by another regimen. And the data from those studies is shown in the bottom right-hand panel. And what you see that in those studies, the evidence suggests that eribulin and paclitaxel are very similar. And you see there the quote in the speech bubble there, looking in the neoadjuvant setting, and we really see no difference between the two. So I think we really can consider eribulin not only to be superior to the later line therapies such as vinorelbine and gemcitabine, but clearly at least as effective, and potentially in some settings more effective than paclitaxel in treating people with metastatic breast cancer. So for me, the clinical trials and the real-world data support the earlier use of eribulin, including in the first-line setting, in particular in the patients who have received an anthracycline and a taxane as part of their treatments for early breast cancer in the neoadjuvant or the adjuvant setting. So now moving towards the end of the slide and looking ahead, we've had access in Europe to eribulin for many years, nearly 15 years in Europe, for more than 15 years in the United States. Eribulin is now established, I think, as chemotherapy of choice after an anthracycline and a taxane. So I think it is appropriate to reevaluate its role in each of these molecular subtypes that we discussed earlier. So I'll just give some examples here and pointers towards the future. In the context of people with hormone receptor positive, HER2 negative metastatic breast cancer, things have moved on considerably in the 15 or more years since the initial eribulin studies, in that we now have multiple treatment options in people with hormone receptor positive disease, including the CDK4/6 inhibitors and the PIK3CA inhibitors. So this is an interesting set of data, real-world data from a group led by Peter Kaufman, who was part of the pivotal trials with eribulin all those years ago. And here they're looking at the real-world progression-free survival and the real-world estimated overall survival in a group of patients who were treated with eribulin after receiving the PI3K inhibitor. And you can see that the data suggests really very encouraging response rates to eribulin. They show an encouraging real-world progression-free survival, and that was seen not only in those who'd received the alpelisib, as it would have been, but also in patients who'd received both alpelisib and a CDK4/6 inhibitor. So these data, I think, are reassuring that the benefits of eribulin in the hormone receptor positive, HER2 negative group of patients are still relevant in the modern era of endocrine therapy. Similarly, another study, the Kelly study, you see summarized on this trial, this looks at combining eribulin with pembrolizumab in hormone receptor positive patients. This was an attempt to identify a group of patients in whom immuno-oncology therapy may give some additional benefits. Again, it's a smallish study, a phase 2 study of just 42 patients, but there was a clinical benefit rate that you see there of over 50%, a response rate of around 40%, and a progression-free survival of 6 months. And you see the responses in the top right panel and the progression-free survival on the bottom right. So this isn't an area where these checkpoint inhibitors have moved forward, but clearly the suggestions are that you can combine eribulin with pembrolizumab. So I think eribulin remains relevant in the checkpoint inhibitor era. Moving on to the people with HER2 positive breast cancer, they did benefit in the context of the pivotal trials, as you'll remember from my earlier slide, but that was looking at eribulin as a single agent in people with HER2 positive breast cancer. This interesting study from Linda Vardat was published many years ago and looked at combining, in a phase 2 study, combining eribulin with trastuzumab as first-line therapy for people with HER2 positive metastatic breast cancer. I think this is a trial that didn't get as much attention as it warranted, but you can see here the data with 52 patients, the vast majority of whom had a response to the combination of eribulin with trastuzumab. The response rates were very encouraging, the PFS data encouraging as well. So these data from many years ago now show that you can indeed substitute eribulin for other chemotherapy in combination with trastuzumab, which I think makes sense, but was something where we had limited data. But if we now fast forward to the current era, because things have moved on for people with HER2 positive metastatic breast cancer, we now use trastuzumab and pertuzumab in this setting. And here you see the report from the Emerald trial, which looked in the first-line setting for people with HER2 positive metastatic breast cancer. And the randomization was between eribulin or a taxane given alongside the combination of trastuzumab and pertuzumab. This was a phase 3 trial, so nearly 450 patients randomized. Of note, the majority of the patients randomized to a taxane received docetaxel rather than paclitaxel, which perhaps doesn't represent our practice these days in the UK. But if you look at the progression-free survival, the progression-free survival favored eribulin over the taxane. The overall survival was 65 months in the taxane group, but hadn't been reached at publication in the eribulin group. And the time to deterioration and quality of life was numerically longer with eribulin than with taxane. So with adverse event rates that were similar and tolerable in both arms, I think here we have really encouraging evidence that eribulin is an alternative to a taxane in combination with HER2 targeted therapy in the first-line setting. Here you see a single study I've selected in people with triple-negative breast cancer. These data were published 3 or 4 years ago now, and this again looked at pembrolizumab combined with eribulin, but here, as I say, in people with metastatic triple-negative disease. 167 patients treated in a phase 1b trial that led into a phase 2. And you can see in the top right-hand panel in both the strata of the trial, which were dividing patients according to their extent of previous treatment for metastatic disease. But in both strata, the response rate to the combination was strikingly high. And in the bottom right-hand panel, you see the Kaplan-Meier curves for PFS, the top 2 panels, and the overall survival on the bottom right. And you can see that in the PD-L1 positive patients, especially in the top panel, you can see the benefit of apparently for in terms of progression-free survival. So if I bring myself towards the end of the presentation, the fourth conclusion is that I think eribulin remains relevant alongside other current treatments in the modern environment of how we treat people with metastatic breast cancer. And just to recap the 4 points, that I think it's important to remember that single agent eribulin improves overall survival across the molecular subtypes, maintains quality of life. That isn't just limited to people with triple-negative breast cancer. There are consistent benefits from using eribulin earlier, a second rather than third line, and now we're seeing data supporting eribulin use in the first or second line setting. The real-world data and the clinical trial data support that first-line and second-line use of eribulin. And as I said in that final selection of slides, eribulin remains very much a relevant agent in the modern treatment armamentarium. So I'll thank you for your attention, and I'm happy to take any questions.
So thank you very much, Professor Chris Twelves, for this extensive and exhaustive review of literature focusing on the use of eribulin in metastatic breast cancer, particularly highlighting the role for its use in earlier lines of treatment. So I think we request you to stay on for the panel, because the questions, I think, will be taken in the panel discussion, and that's going to be conducted by none other than Dr. Ankur Bahel, who's the Principal Director of Medical Oncology at Fortis Gurgaon. So I think his job is to strategize, select patients, and pose some real-world case challenges to the panelists to get the best out of eribulin. Ankur?
Yes, sir. Thank you so much, Dr. Shyam Agarwal, sir, and thank you, Gennova, and warm regards to our international speaker, Professor Twills. So I've been using eribulin. We have all been using eribulin for more than a decade, and when we were using at that time in India, when the biomarkers, the genomics, the BRCA-ness, the platinum sensitivity, the olaparib maintenance, and the keynote trials were not there. So now we are much mature in deciding the strategy, the second line, third line, beyond in triple negative breast cancer. And I welcome all my panelists, and I will request Professor to stay so that we can have quick round of question. And I sincere apology for not being on video because I'm in a poor connectivity. So it will be an audio panel. And so we have 9 panelists with Professor and Dr. Shyam Agarwal, sir. So we'll be having a quick round of questions to each panelist in a structured way so that we can give justice to eribulin in current practice. So Professor, first 2-3 questions to you. So my first question is, you have shown us the evidence, the global evidence, as well as your clinical experience at Leeds. The strongest rationale of considering eribulin in earlier treatment rather than in third line or fourth line. We just want to hear you now. What are the practical things, whether the dropouts from eribulin, the amount of thrombocytopenia, neutropenia, the tolerance, that fatigue is much, I consider it as a higher when we use it in a later lines rather than we use it at an earlier line. And when we have a pembrolizumab and the genomics with us, how do you rate this practice in current era in 2026, Professor?
Thank you. So I think that our frustration in the UK is that we don't have access to earlier line eribulin. But certainly if we did have, we would use it earlier. I think the first reason that is this issue of attrition, that about 30% or more of patients don't go on to receive each subsequent line of therapy. So I think that really runs a risk of patients missing out on important lines of treatment. So I don't think it makes sense to save the more effective treatments until later in the natural history of the disease. I think the argument for earlier use is particularly strong in the patients who have received the anthracycline and the taxane in the perioperative setting, and then who have relatively early relapse. Those patients are likely to have less rather than more sensitivity to the anthracycline or to the taxane. So to introduce eribulin sooner seems to make sense, and that's very much borne out by the data that you showed. Now, clearly, there will be settings and situations where the first line use of eribulin may not be optimal. I think the triple negative PD-L1 positive patients are ones where we would still be more comfortable with the more standard approach, in combining other chemotherapy with the checkpoint inhibitor But I think we still would have the issue beyond that treatment, where to go next. And again, I think eribulin, we know, is particularly effective in triple-negative breast cancer. So I think in each of the disease settings we can make the argument, but in particular the ones that I've just given. And I think your point about the better tolerability of chemotherapy in general in the earlier line setting rather than the later line setting is another important consideration.
Yeah, thank you so much. Can we have the next question for Professor? So in real world practice, how do you actually differentiate that which patient are more likely to benefit from eribulin versus capecitabine or any other agent when it considered thinking about the biology, prior anthracycline, taxanes, or symptom burden? So how do you choose if we have to choose if the patient has got anthracycline, taxanes, probably platinums also? So how would you choose that we should start eribulin and capecitabine? Because Dr. Shyam Agarwal emphasized that it's a daycare procedure. Patient has to come for a very short infusion. The burden to the daycare facility is not that much with eribulin. But still, how do you decide cape versus eribulin if you have to, depending on the patient profile, phenotype or genotype?
So you're posing an interesting question, because the two cytotoxics that I've been most closely involved in the development of are precisely eribulin and capecitabine. So you're effectively putting me in the position of having to choose which of my two children is my favorite. Having said that, I think from the wider question for me is less eribulin versus capecitabine than the earlier rather than later. Because in reality, if your first line treatment is with capecitabine, then I think your second line treatment could very reasonably be with eribulin, or vice versa. That attrition between first and second line is less than we see that cumulative attrition as we get into the fifth line, fourth or fifth line settings, where we see the current majority of use of eribulin apparently in India. So I think these are both good treatments. I don't know that there's a particular subtype or characteristic of disease biology that would select between one or the other. Most patients will have received an anthracycline or a taxane. It's been postulated that because one of the things that we saw in the EMBRACE study was that people treated with eribulin and people treated with the TPC had similar PFS, but the overall survival was better with eribulin. It was postulated that this might have something to do with changing the biology of the disease, so that we get a reversion, that when the patients progress on eribulin, they may progress with less aggressive disease. That may be another reason for preferring the earlier use of eribulin in particular.
Absolutely right. Both are wonderful drugs, and physician discretion, equal PFS might be a better survival, as you said, in EMBRACE. But yes, sir.
Yeah, I think the more pressing question which is coming to my mind is, in a patient who's triple negative and who is not a candidate for Pembro, would you use platinum-based therapy or eribulin, after having used, taxane and Enthra?
So, Professor Chris, so it depends upon patient to patient whether patient has got some neoadjuvant, adjuvant therapy. BRCA is a habit in our country, or doing in triple negative. So, what are the genotype, phenotype? At least phenotype is a BRCA history, a family history. So all these points will decide whether to use platinums or use eribulin before, or use only capecitabine. So it may vary from patient to patient. And the burden, and the professor also said about the response rate, the waterfall curves. So Professor, your comments, platinums, where does platinum comes in triple negative state?
I think that the people with triple negative breast cancer, we want them to have been exposed to platinum. Many of them will have been exposed to the platinum in the adjuvant or the neoadjuvant setting. And there, I think the argument for eribulin is particularly compelling. if they've not received platinum previously, then you would want them to receive it in the metastatic setting, either before or after eribulin. I think capecitabine in the triple negative setting, I am less enthusiastic about. I think the data in study 301 are quite convincing. I'm not entirely convinced by the data showing that patients may do better with post-operative capecitabine after neoadjuvant chemotherapy. So I'd put the eribulin and the platinum well ahead of capecitabine in triple negative disease. The patients with the BRCA mutations, clearly we want to give them the chance to benefit from talazoparib or olaparib, but they're a relatively small minority of patients.
Thank you so much, Professor. I think we'll give you a breather now, and I'll ask other panelists, you need a break. Thank you so much. Next slide, please. Next slide. Yeah. So question to Dr. P.N. Mohapatra from Kolkata. Sir, from your great Indian clinical perspective and your experience, what has been your real world experience with this drug when it comes to response durability, symptom control, and the quality of life, particularly in our set of patients? So our set of patients who are metastatic, who have got neoadjuvant, adjuvant therapy, they are exposed to multiple lines of therapy, and we all practice in a government or a public sector. So what is your experience when it comes to eribulin in metastatic? Dr. Mohapatra, sir.
I think it's a very excellent drug, actually, especially in triple negative and hormone positive. In hormone positive, we use lead. So a lot of patient I've given eribulin, actually, it's a real world experience I'm telling, actually. When there is nothing like that, we have given eribulin and them done well without any toxicity, actually. This is in triple negative, we use little early. I've used 2 patients, actually, 2-3 patients in actually they came from other centers. They have not done HER2 properly, and they have received taxanes and adriamycin based chemotherapy, and suddenly they came with no response, and we tested, and it's a HER2 positive. We have given eribulin with Trastuzumab and Pertuzumab, and we have seen excellent response, actually. Both in I've given some very later line treatments with eribulin with Trastuzumab also, after all HER2 failures, and some patients who are not very affording, actually. I've seen good results, actually. My real life experience is good. Actually, the patient respond well for some time without less toxicity. And after that, when the patient become well, and you can use subsequent lines of treatments.
So absolutely right. And I think you are echoing with Professor that the response is there, symptoms get control, you get a clinical benefit response rate easily, and you can wet it down with your scans, either CT or PET scan. And the quality of life, I believe that it is maintained if it is used early, and then we have subsequent lines of therapy in triple negative state. Thank you so much, Dr. Mohapatra. Next question, please. So next question is again from Kolkata, Dr. Chandrakant MV. So Dr. Chandrakant, are you there?
Hi, sir. Good evening.
Yes, good evening. So do you observe that your improved outcomes when eribulin is used earlier? I think this is a repeat question, but yes, if it is used earlier than a later line, if you use eribulin as a 4th line or 5th line, suppose a de novo metastatic patient comes to you and you have given taxanes and PDL1 is higher, you have given taxanes plus Keytruda, and then the patient progresses, you have given lipodox or platinum or gemcitabine and platinum, then you have given capecitabine, and then patient is still holding on the performance status. So where do you want to place eribulin? This is a real life question which everybody addresses in practice. So where want you to place eribulin in your practice? 2nd line, 3rd line, 4th line, or maybe beyond also? Dr. Chandrakant.
Right, sir. So thanks for that question, a very valid question. In the present day, we see even metastatic triple negative breast cancer patients receiving 3rd line, 4th line, and beyond, and that's a great thing because the supportive care and ADC is coming in the earlier lines. So one thing what we need to remember is the mechanism of action of eribulin is different from a paclitaxel.
I mean, a taxane or from a vinca alkaloid. So they are, even though all of them are tubule poisons, they're not cross resistant. Therefore, even in a heavily pre-treated patient with anthracycline and taxane, this agent works. And you hardly have an agent that is heavily pre-treated but shows an overall survival benefit. So when you have a drug that has shown an overall survival benefit, we would like to expose our patients to this drug as early as possible. So at least in a patient who is anthra-taxane exposed, in these patients, I would like to use eribulin early on, because earlier you use, the greater the benefit is. That is for any other drug. But overall survival benefit is the one that makes me use the drug early on. The barriers which I face are, of course, capecitabine is an oral drug. That's the ease of administering this drug. And then secondly, of course, the cost and the access is also an issue. And so whatever in practice we experience patients on eribulin having a long PFS or long durability is just reflected even in the Embrace and the study 301. So earlier use, better it is because of the overall survival benefit we have.
Thank you. Thank you so much, Dr. Chandrakant. So, Professor, are you there? Professor Twills, are you there? So, okay.
Yes, I am. Sorry.
So we India is a diverse country, and we have a huge patient load. And diverse country means that we have patients who can afford and who are not able to afford, paying out of their pocket. So we are entering into an era of ADCs. Saxituzumab govitecan is available in our country. So how do you want to place this ADC with eribulin in your practice? Because that's a wonderful drug too and has a data in triple negative. So where do you want to place antibody drug conjugate in the immunotherapy era, in the olaparib era? Where does ADC stand and where does eribulin stand when it comes to different agent? Because Dr. Chandrakant rightly said mechanism of action.
No, there will be patients where the genomics, for example, point you in a particular direction around the checkpoint inhibitor. The ADCs are certainly effective. We use sacituzumab increasingly in the earlier rather than the later line therapy. But again, I think the key mindset for me is to be thinking about these, what I consider premier agents, which would be in the PD-L1 positive, the chemotherapy with pembro, in the patients with the BRCA mutation, we've got talazoparib or we've got olaparib. But we should be thinking about whether it's those agents or a platinum or eribulin. So I think those are the discussions I'd like to think we were having, rather than reserving the use of eribulin until the later line. As I say, I think the first, second line and how we juggle the two will depend on patient preference, financial, and other things, other considerations, as well as the genomics. But what I think is important is that we're front loading our treatment of metastatic breast cancer with the more effective agents, not the also rans. And eribulin, I think, is clearly positioned at the top table, if you like, as one that we should be considering sooner rather than later. But it won't be the same identical sequence for all patients any more than it is for whether we use chemotherapy or hormone therapy first in people with hormone receptor positive metastatic breast cancer. The patient considerations do differ. But we do need to be using these better agents sooner rather than later.
Thank you. Thank you so much for this explanation. Over to the next question to another panelist. Dr. Pankaj Goel. Again, a very busy practice. Dr. Pankaj Goel comes from north part of the India, Rajiv Gandhi Cancer Institute, New Delhi. So Dr. Pankaj, are you there?
Yes, sir. Yes, sir.
So again, similar question. to you eribulin versus capecitabine in routine compliance, which is very important. At times, you don't even check compliance. You give capecitabine 3 tablets, 2 tablets in the evening. Less doses, not even the full dose of 2 gram per meter square. Lots of hand-foot syndrome, mucositis, but yes, cost is less. Initial patient preferences towards capecitabine. How do you practice eribulin versus capecitabine?
So, sir, I prefer when the patient's having a better performance status and when the patient can take full dose of the treatment. It's better to give the injectable eribulin in the previous in the lines first before capecitabine. And capecitabine, even if you use in the previous lines, we are not able to give the full dose, so we cannot expect that good PFS with these patients. So when the patients are actually exhausted and they say just simply strict no to injectable and they cannot come, then I go for capecitabine. And in fact, there are few patients in which the disease volume is very high. In those patients, at times, I have used these both the drugs in combination as well. So there'll be three segment of patients in which some patients high volume load I might use in combination. Then the other patient in which preferably I will use eribulin if peripheral neuropathy is not a big issue. And if there are patients are having major issues with peripheral neuropathy because of previous taxane usage, at times I do give capecitabine so that they have recovery and then we can give that. So preferably eribulin as early as possible.
So, Dr. Pankaj, if I misunderstood, you're talking about combination of eribulin and Xeloda?
Sir, I have used that combination also if the disease volume is high.
Okay. So Professor, quick comment on this combination.
No, that's it. That's interesting. It's not a combination that I've been able to use. I think it's a very reasonable combination. So I'd be interested to see some data on using the two agents together. One comment I would make is that if I remember when we looked at the eribulin data many years ago in the large scale phase 3 trials, the incidence of peripheral neuropathy, the significant peripheral neuropathy was pretty low. I can't remember the exact figure, but interestingly, it didn't seem to be a particular problem in people who went into trials with a degree of pre-existing neuropathy. So the majority of patients in 301 and 305 who went into the trial with pre-existing neuropathy were able to receive eribulin. So we shouldn't necessarily assume that because somebody has a degree of pre-existing neuropathy, it will necessarily get worse with eribulin.
Ankur.
Yes, sir. Yes, sir.
It's Pankaj. Pankaj, I want, or maybe to Professor Twelves. So if you have a patient who has failed, taxane, anthra, and even platinum in the adjuvant or neoadjuvant, so would you use eribulin plus pembro or use sacituzumab plus pembro in the first line?
We'd probably use chemotherapy plus pembro, but we wouldn't have the option of eribulin plus pembro. Had we the option, then especially in somebody who's been exposed to prior platinum, then it would be a quite reasonable, quite logical to look at the eribulin combination.
Yes. So I think we should move on. We have just few minutes left. Next panelist. Thank you, Dr. Pankaj, for this new combination insight that was missing from my practice at least.
Yes, sir.
So this next question is to Dr. Arun Raja, sir. So Dr. Arun, are you there? Dr. Arun? Okay. Dr. Arun. So next question, please. So Dr. Prasad. Dr. Prasad, are you there?
Yes.
So good evening, sir. So how much, so when we talk about the safety and toxicity profile of eribulin, we know with capecitabine, with taxane, they're predictable. So how bad has your patient gone on eribulin and how smooth your patient has gone on eribulin? We need some real world examples from your side.
I would share my little experience. I have at least 380 plus women who are on eribulin for the past 1.5 to 2.5 years. 80 plus in a very good general condition. Start dose 2 milligrams. The only thing what I do in my practice is instead of giving it as on day 1 and day 8 every 21 days, I give it at day 1 and day 11. 3 days. That's probably helping most of the patients. They just come to the outpatient OPD area, get the IV injection, and go home. That's it.
So day 1 and day 11 is as per your previous patient getting neutropenia and growth factors, and then you decided
Yes,
day 1 and day 11. So that's
day
your
11.
experience.
Yes, yes,
Yeah.
yes, yes.
So, Professor, when we give eribulin in day 1, day 8, we have seen that in our practice, the day 8 get delayed by 2-3 days. We might have to delay. Patient emails us the reports, thrombocytopenia or neutropenia. Then you predict that this patient might require some more days. So, Dr. Prasad has developed his own style that day 1, day 11. That's fair, but that was not in the trial, not in the embrace. How do you see the delay in your patients when it comes to day 8 delivery of the cycle? What is your threshold of platelets and TLC when it comes to delivery of day 8 dose of the subsequent cycles? Professor, and then we can hear Dr. Prasad comments as well.
Yes.
For the day 8, we'd usually be looking for a neutrophil count of over 1, platelets over 75. I think you raised an important point, because the concern if people miss their day 8 dose is that they're getting a 50% dose reduction for that cycle. So where we do it, so we tend to do that, but we then make the dose adjustment for the next cycle so that we reduce the day 1 dose, so that we hope then to get the day 1 and the day 8 dose in together. But I think the delay is interesting. I will just say one anecdote. I saw a patient a year or two ago in clinic, an extra patient, and the nurses brought the patient into me because they told me that this patient was taking the E drug that I was so keen on. So they brought the patient in, and I sat down, and I was hoping for a nice friendly consultation with this patient on eribulin. And I said, I smiled at her and said, "How did you get on with my drug?" She said, "Dreadful. I've never felt so bad. Worst drug I've ever had." Oh dear. What was the problem? Oh, it was dreadful. I'm never taking those tablets again. It was everolimus that she was taking alongside
Yes,
exemestane.
E
She'd got
plus
the
E,
wrong E.
Bolero 2, Bolero 3 trial you're talking about. The
But it
God,
wasn't
yes.
eribulin.
Yes. So very interesting situation where Dr. Prasad says that day 11, day 1, day 11, his practice in a geriatric oncology patients, and professor saying that it happens and it's not bad to change our practice as per the previous experiences. Thank you, Dr. Prasad, for
So
this wonderful. So we got two situations.
one
Yes,
additional
sir.
thing. I
Yes, sir.
mean, initially I was practicing day 1, day 8, and every 21 days. So most of the time we end up reducing the dose, or patient getting the appointments cancelled because of the low WBCs or low platelets. And most of the patients come from outstations. So we don't want them to come get the blood test done if it is not good enough, and then they go back. But nowadays with the day 1 and day 11, especially this 80 plus, I'm able to give them the full dose without any much neutropenia, and this very compliant for all the patients, because we give the adequate time for the recovery. Anyway, when the counts are low on day 8, we are going to postpone it. So why to even make the patient come to the hospital twice? I had changed it to day 11. That's the reason of changing it to day
Yes.
11.
So actually, I'm maintaining the dose, the density, and
2 mgs. Yes.
yes. Thank you so much for this idea. Over to the next panelist, please. So, Dr. Anuradha Mehta, are you there?
Yes, sir. Good evening, sir.
Good evening. So you have heard Professor and our colleagues. So, what insights from the pivotal trials such as Emerald influences your confidence when it comes to eribulin earlier than to data that translates to the Indian patient? Dr. Akhil Kapoor from Varanasi showed his data as well. Professor showed the global data. You've heard previous speakers. So how you incorporate the trial into your practice? I know it's difficult. The performance status, the inclusion criteria are certainly different. It's not matching our real world practice, but how does your practice match with the trials when it comes to medical oncology practice in TNBC.
So, sir, thanks to Professor Twells, his extensive review of literature actually gave me a lot of confidence, and especially that Emerald study. Using the Cleopatra regimen has always been our go-to first-line regimen in HER2 positive MBC. But as Professor mentioned, that the median OS was not reached in the eribulin arm, and the PFS was similar in both the arms, with not much deterioration in quality of life. I think it gives us a lot of confidence to bring eribulin to the first line setting. Also, in few of our TNBC patients, we have been who have unfortunately after neoadjuvant chemotherapy surgery and on adjuvant capecitabine have been progressed on during their adjuvant capecitabine therapy. So our go-to regimen has been eribulin, and I've used it in a quite a lot of patients, usually poor patients who cannot afford immunotherapy, and the responses and the side effect profile has been quite manageable, and it is quite well tolerated drug even with the day 1 day 8 regimen.
Yeah, a very, very crisp and very clear answer from Dr. Anuradha. So I think we don't have any doubts on the practice we all do with eribulin and triple negative. Next panel, please. Next panel question, please. So Dr. Mansi, are you there?
Yes, I'm here. Hi.
Thank you, Dr. Mansi. So with increasing treatment option, we have seen from taxanes to anthracycline to platinum, gemcitabine, capecitabine, ADCs. How do you practically sequence? Give me your 3 or 4 examples of sequencing in a patient who has got neoadjuvant, adjuvant, and further, and a metastatic to de novo metastatic and de novo TNBC early breast cancer.
So when we're talking about, so you're asking about primarily TNBC
Yes,
patients,
let's
right?
start with the keynote trial, early breast cancer, T2N0M0, who has been taking treatment, and then it progresses. Just a quick sequence of the events we can go through.
So I think the bottom line is whenever you're planning to give chemotherapy to a triple negative patient in the metastatic setting. So in the first setting, if the patient has gotten keynote 522 for the treatment of early triple negative breast cancer, and then the patient has recurred, we have used pretty much all agents, and I would definitely use eribulin first line in this patient. If we're thinking of chemotherapy alone, assuming the patient is BRCA negative, we don't obviously have any head-to-head comparisons in terms of using the other ADCs like trastuzumab deruxtecan with eribulin, like a head-to-head in the first line setting. So it'd be hard to say, but whenever we're using chemotherapy, use eribulin upfront is probably a better idea. I've also used in triple negative breast cancer patients who have a huge tumor burden. Like there will be certain patients that are refractory, although not like a large number. I've used eribulin in combination with bevacizumab to get like a better overall response rate. And that also has been a pretty good regimen in my experience. We know that there is no overall survival benefit with Bev, but I think that has also helped for refractory patients. So I think eribulin also works in those patients when we don't have.
Very, very rightly said. Heavily pre-treated. I would say frustrated triple negative breast cancer because these patients are young. Triple negative cohort is young, and that's not rare to see a triple negative patient who has been exposed over the years, multiple lines of therapy, and then eribulin, as everybody is saying, bring it earlier rather than late for that overall survival benefit. Professor, coming to you, have you re-challenged eribulin ever in your patients? Eribulin got a response, next line, and then giving eribulin again. Does it happen in real practice, Professor Christopher?
It's not something that I've done when I've certainly had patients on eribulin who have had a response, and then they've either wanted a treatment break because they were going away, or sometimes because they've started to get some toxicity. Well, we've given them a treatment break and then reintroduced the eribulin when they progressed. but that's not quite the same situation as if a patient who progresses on treatment. I think if a patient progresses on treatment, the likelihood of getting a response after a drug holiday, when you reintroduce that drug, is very low. But I think where you have a patient who's discontinued due to the patient choice, due to toxicity, and those toxicities may include financial toxicity if the patient is struggling to afford their care. Then in that situation where they've had a drug holiday as a reason for their time of treatment, rather than them progressing on the eribulin, if it's a drug holiday they've had, then I would certainly consider reintroducing eribulin, and I have done in the past.
Thank you so much, Professor. Next question. Thank you, Dr. Mansi. Dr. Amit Bhatt from Pune. Thank you, Dr. Amit, and thank you for waiting so much. I know the last two questions. So in patients with rapidly progressive or symptomatic visceral disease, we have heard previous speaker, multiple liver metastasis, lung metastasis, cannonball, bone metastasis. Now the performance status is going down, and colleagues have given over 80 plus, manipulated the protocol. So any advantage in disease control in a very heavily burdened, what would be those red flag which you see before giving eribulin? Dr. Ahmed Bhatt, sir.
Good evening, Dr. Ankur, and good evening, panelists. A short answer to this is, see, if you look at eribulin, it's actually, we are impressed with whatever eribulin has to offer to us, because after multiple lines of therapy, it still gives an overall OS advantage. So very few drugs we have in today's practice which gives the kind of OS advantage which eribulin gives. But if there's a patient who has a rapidly progressive disease or impending visceral crisis, the short answer to this is probably eribulin is not my go-to drug right now, because the way we see the response, if you want a quicker response, I might just go on to platinum or using platinum or gemcite again. So eribulin, I feel that eribulin is more of a marathon drug. It works in almost all the situations, post multiple line of therapies, elderly, frail patients. So it's really a wonderful drug. But when it comes to the situation where you need say there is an impending visceral crisis or the patient needs really rapid response, then eribulin won't be my drug of choice. It's not a 100-meter sprint drug. It's more of a marathon drug, which gives you good long-lasting advantage. But a quicker advantage, eribulin would not be the drug of choice. There was a mention about using Xeloda and eribulin together. So as far as I remember, it was used in HER2/neu early stage as an adjuvant therapy, and probably it miserably failed. So I'm not sure. I haven't heard about anyone using Xeloda and eribulin really in discussions till now together for a rapidly progressive disease. But again, I'll be happy re-challenging platinum than anything else if I have a rapidly progressive TNBC.
So yes, we can hear you, Dr. Bhatt, for this different flavor. And to my practice, I don't know. I always check my patient albumin levels before giving eribulin. So the kind of neuropathy, the cytopenias, and the toxicity, fatigue especially. So if albumin is lower, so I do not give this microtubule inhibitors or tubule inhibitors, because it can have a different side effect profile. Thank you so much, Dr. Bhatt. Next question, please. Dr. Akash Tiwari from Indore. Are you there, Dr. Akash?
Hi, sir. Yes, sir, I'm around.
Yes. Any difficulty in challenges related to access, affordability, or infusion logistic with this drug? So very simple drug, walk-in, vials are available, not that much costly. So any accessibility difficulty to this drug in this era, 2026 India?
So, sir, not accessibility issue, but cost, yes. So infusions are not that much because it is a short infusion. But there are two challenges that our patients face. One is purely of cost, and one, patients who are traveling for long distances, a day 1, day 8 infusion. Other than that, I don't think there is an issue. I think sometimes in our part of the country, there's also this awareness gap. Sometimes when people have used eribulin in later lines, they don't tend to get that good a response, and then they don't tend to reuse the drug again. So I think that is also a challenge that is there in under usage of the drug. Yeah.
Absolutely rightly said. Not that much challenge. Yes, just cost is a factor when you compare with taxanes and platinum. And I could recall two patients of mine. So those both were triple negative patients on a adjacent couch. One was getting cisplatin and gemcitabine, other was getting eribulin, and both were talking to each other by removing the curtain. And the cisplatin patient was so jealous of eribulin patient that she comes early and she goes early while she has to take all the fluids, mannitol and potassium and magnesium. So you rightly said it's a comfort to the patient, might be a discomfort to the pocket when compared to other conventional agent. But yes, it deserves applause and it deserves respect when it comes to earlier usage in triple negative breast
It
cancer.
does.
Next question. So I think we are offshooting all the time. We have discussed in last 40 minutes the real challenges, the ground level challenges, cost challenges, accessibility, sequencing, the use of these drugs, how to use it judiciously, red flags, toxicity, quality, manipulation, adherence to the trial. I think if any more questions we can discuss in chat box or further. So everybody is waiting for their own dinner at their own home. Over to the organizers and Professor Agarwal, Sham Agarwal sir. And thank you so much, Professor Christopher, for this wonderful attendance. Over to Dr. Sham Agarwal and the organizers.
Yeah, so before I make a comment, is Professor Chris is there? So we like to hear your last comment, sir, before we conclude the session, since you are the senior most.
My last comment is that I wish I was with you in India and I've got a wonderful Indian meal to look forward to now. Instead, I'm in England. It's the middle of the afternoon. It's cloudy and it's raining. So I think
I was in London last week, so it was pretty cold and rainy out there. So great. Akhil, any last minute comment since you have large experience with the drug?
No, I think I think when eribulin was first introduced, it was associated with this when all other options have been exhausted, and I think that mindset had stuck with us rather too long, because even in the early days, the data showed that it was better used sooner rather than much later, and I think now we're seeing that using even sooner is better than sooner. So I think we should be thinking of eribulin as one of our, I think of them as our Premier League drugs in treating metastatic breast cancer. So I think we should have the mindset that eribulin is one of our top drugs, not one that we hold in reserve until everything else has failed.
Sure. Akhil?
Yeah. I think Professor has already summarized very important comments. Using them earlier, using them in combination wherever required. We have utilized even in combination with immunotherapy. I think data is already there for HER2 combination. So I think these are the key to utilize. And I highlighted the data of TMH Mumbai where Professor Gupta sir has utilized it in combination with hormonal agents. So I think all these areas are there where the expected PFS and the benefit from the treatment will improve when you use it early and in combination. Thank you, sir.
So I think I'm going to request Chandrakant to make a cartoon because he's so popular and he's so good at making cartoons, showcasing the use of eribulin in earlier lines than later. So I think the drug really started as a backbencher and now it's come to the front line, particularly in TNBC, and also now can be used in combination with pembrolizumab or trastuzumab, wherever it is suitable. So I think we actually are spoiled for choices today because of the availability of several chemotherapy options. But eribulin requires early line integration for the best outcomes. So I think I thank all the speakers and Professor Chris Twells for sparing his valuable time with us and giving his words of wisdom for how to treat patients with metastatic breast cancer. So over to you, Ronak. Thank you very much.
Thank you
so much. Thank you so much, Professor. It was really enlightening to hear you as well, give your perspective. And thank you so much, all our panelists and esteemed faculty, for taking out the time and sharing your valuable clinical insights. So have a good weekend. Thank you so much, everyone from Team Gennova. Bye-bye.
Thank you. Good night.
Goodbye.
Good night.